Welcome, everyone, and thank you for joining us today. My colleagues and I are part of Stony Brook Medicine's Department of Obstetrics, Gynecology, and Reproductive Medicine. We're going to focus our discussion today on minimally invasive gynecologic surgery, really improving lives through technology. And this has become a very timely topic as many OB/GYN surgeries can now be performed using minimally invasive techniques. I'm Dr. Todd Griffin. I'm clinical professor and chair of Obstetrics, Gynecology, and Reproductive Medicine at Stony Brook Medicine. I'm an obstetrician gynecologist, but I specialize in robotics, laparoscopy, and minimally invasive gynecologic surgery. I'm joined by 4 experts from our department: Dr. William Burke, Director of Gynecologic Oncology, Dr. Sarah Kim, and Dr. Julie Leanne, who are part of our minimally invasive gynecologic surgery division, and Dr. Andre Player, who is a urogynecologist. I'm going to have them introduce themselves to get started. So let's start with you, Dr. Burke. Can you tell us a little about your role within the Cancer Center?
Sure, thanks, Todd. Hi, yes, I'm the Division Director of Gynecologic Oncology. Within the Cancer Center, I direct our group's effort in coordinating comprehensive, compassionate, and innovative care for women with gynecologic cancers, which include ovary cancer, uterine cancer, vulvar cancer, cervix, and vaginal cancer.
Next on the panel, we'll go to Dr. Kim.
Hello, everyone. My name is Sarah Kim, and I am a benign gynecologic surgeon. I specialize very similar to Dr. Griffin in treating benign conditions via minimally invasive approach, whether that's robotics, laparoscopy, or hysteroscopy. And then I'm very happy to be here. Actually, 3 of my mentors are here: Dr. Burke, Dr. Griffin, Dr. Leanne. So it's a privilege to be part of this panel today.
Next, we'll move to Dr. Leanne. If you can introduce yourself and talk a little about the surgery that you do.
Good afternoon, everyone. Happy to be here. So I specialize in benign complex gynecology, but I also offer well woman care as well. Trained with Dr. Griffin, so I offer surgery through minimally invasive techniques such as robotics, hysteroscopy, and laparoscopy.
And last but definitely not least, Dr. Player, if you could introduce yourself and talk about what you specialize in.
Hi, yes. Hello, everyone. I'm a urogynecologist here at Stony Brook, which means that I specialize in conditions that affect vaginal and bladder functioning. Some of the most common conditions that urogynecologists treat are vaginal prolapse, as well as urinary leaking issues. However, we do cover a wider range of issues, including recurrent urinary tract infections, voiding dysfunction, pelvic floor weakness or tightness, as well as stool leaking as well.
Okay, great. So I just want to encourage our viewers that they can type in their questions in the comments section, and we'll do our best to address them. And we're going to get started with some of my questions for the panel. So the first question I'm going to direct towards Dr. Burke. And if we could show slide 1, could you tell us what is minimally invasive gynecologic surgery? When did it start? And really, how has it evolved over the years?
Sure. So minimally invasive surgery was a concept of allowing surgeons to complete surgeries that were typically done with large incisions to be done with smaller incisions guided by precision instrumentation and optics. And so the birth of minimally invasive surgery really was in the late 60s and early 70s, where surgeons started using visual scopes to look inside the uterus and perform some simple procedures such as tubal ligations. Really, the heyday of minimally invasive surgery really started in the late 80s and early 90s, where laparoscopic techniques using video cameras, small incisions, and energy devices allowed us to start doing complicated surgeries such as hysterectomies and myomectomies via small incisions. This has kind of exploded through the 2000s with the introduction of robotics, specifically right now, the Da Vinci surgical system, which really kind of hit its stride for gynecologic surgery in 2005, 2006, and now to current day, where we have single incision platforms and advanced operative systems.
Great. My next question, I'm going to move on to actually 3 of our panelists and really talk about the different techniques that are available today. So I'm going to start with Dr. Player. If you could talk a little about vaginal surgery and how that's really been changed over the years and how that can help women from a minimally invasive perspective.
Yes, so vaginal surgery is really the original minimally invasive surgery. There are many of the techniques that have improved over time, but the adage is still the same, that the smallest incision on the belly really is the one that you don't have to make. There are certain procedures that can only be done through the vagina, but there are certain procedures that have the option of different routes of approach, such as hysterectomies, incontinence procedures, and vaginal prolapse repairs. And these procedures all have vaginal approach options. Another thing to consider within the vaginal surgery world is that there is a increasing use of uterine preservation surgeries for vaginal prolapse cases where you may not need to remove the uterus for patients for whom that is not a good plan for.
Great. And I think if Dr. Leanne, if you could talk to us a little about laparoscopy and what that is, and if we could show image 1, that would be helpful.
So laparoscopy really offers us to, instead of making one large incision on the abdomen, either cross or up and down, we basically make either up from one small incision to up to 4 to 5, depending on someone's condition for which we're doing the surgery for. And the incisions range from, a couple of millimeters to up to 1 centimeter. And as you can see in that picture, we use a very small camera that we can look inside the abdomen and pelvis. And then the other incisions allow us to put other surgical instruments through, so we can, whatever the surgery is intended for, either for a cystectomy, fibroid removal, hysterectomy. So it allows us to make multiple small incisions instead of one large incision.
And then next, we'll move on to Dr. Kim to talk to us a little about robotics, and if we could show slide 2.
So robotic surgery is in many ways very similar to just conventional laparoscopy. The concepts are pretty much the same in the sense that robotics approach utilizes the several small stroke cards that you saw before in the previous slide. The instruments are wristed, and we'll kind of go into the differences a little bit between laparoscopy and robotics a little bit further on in the talk. But wristed just kind of means that the instruments, instead of being straight, you could kind of turn it, left and right, and it's articulated. And you also have 3D vision, meaning that when you're sitting on the console, where the surgeon sits to control the robotic arms, you're able to, and you could show actually image 3 to kind of show the dual console. So the surgeon is able to sit on the console and is controlling the robotic arms by using the little hand controls. And so the instruments respond to the movement of the surgeon, and you're able to see 3D vision through the console itself. When the surgeon physically moves around, the robotic arms also move around as well. But the concepts are pretty much the same. It's just that you have a distance between the actual the patient, because with conventional laparoscopy, the surgeon is actually controlling the arms directly next to the patient. You want to show the video 1 to kind of show how the robot is controlled. That kind of gives better sense. And here you can see the surgeon is moving the hand controls, and you can see the robot in the distance where the robotic instruments are moving, and the surgeon is sitting on the console. And so although the robot is docked next to the patient, the robot is always controlled by the surgeon, that hand, and it basically helps and facilitates the surgery itself.
And I think that's an important concept, because I think many people think when they hear about robotic surgery, they think it's like the robot's doing the surgery, you're pushing a button, and it's really, we're just controlling it. It's a different platform. So I think that's a really good explanation. And I appreciate you guys explaining the differences really between vaginal, laparoscopy, and robotics. And I think it's important, again, for patients to understand really what are the different benefits of these minimally invasive techniques. And I'll throw that back to both Dr. Kim and Dr. Leanne. And maybe we could show slide 3.
Mm-hmm. Dr. Leanne, do you want to?
Sure, I can start.
Yeah. Mm-hmm.
So with both robotics and laparoscopy, there's a couple of small incisions, generally up to 4 to 5, and again, they're up to 1 centimeter in size. And so because of those smaller incisions, there's generally less pain that people feel postoperatively, which means greater or faster recovery and return to work and normal activities. And in general, after these type of surgeries, people are able to go home generally the same day, or if needed, stay overnight. But most people are able to go home the same day and recover at the comforts of their home.
Right. And in sort of the incisions, if you want to kind of, we could show image 4, kind of showing where the distribution of the incisions are. As you can see, kind of more visualization of the difference between the open what we call transverse incision, which you can see the lower in the abdomen, kind of large incision, and very small, anywhere ranging from 3 millimeters to 1 centimeter incisions, kind of lower pelvis, and for this specific one, myomectomy incisions and near the belly button. And kind of going back, further expanding upon the benefits. In not only overall less pain post-op, improved recovery, shorter hospital stay. So it also increases a lot of times patient satisfaction. They're very happy they're able to go home quicker and able to actually recover quicker. And we also, I think Dr. Lan is also critical in developing the ERAS protocols at our hospital, which is early recovery after surgery, with a focus on, decrease in post-op nausea, decrease in post-op pain, which translates into also decreased use of post-op narcotics, needing less pain medications afterwards. So it kind of highlights that overall, the minimally invasive approach is able to improve patient care in the sense of that they're able to recover quicker, have less surgical site infections, and also decrease hospital stay.
So when you talk about recovery, you guys were talking about it's a quicker recovery. So with a traditional open surgery, what would be the traditional recovery time that you would see for that type of patient versus a laparoscopic or robotic case? What would be, so just so the audience understands the difference in recovery time?
So generally, I would tell patients if they were, we were anticipating needing to do a larger incision. We'll talk later in this live stream about, when would a larger incision be more appropriate. But generally, the recovery is a little bit longer. So I generally say 4 to 6 weeks recovering after that type of surgery. But generally, for laparoscopic or robotic surgery, it's anywhere from 2 to 3 weeks to 2 to 4 weeks. But really, in terms of pain after surgery, generally by the end of the first week after surgery, people feel a lot better after laparoscopic or robotics.
Great.
Yeah.
And I think, that's a really important point to make, is that the recovery time is dramatically different for the laparoscopic or robotic approaches. And again, most people, like you said, are feeling pretty good in 1 to 2 weeks, most are recovering between 2 to 4 weeks. Whereas with an open surgery, again, we're going to see that be more on the 4 to 6, even 8-week time period sometimes. So great. So next I want to talk a little about what are the differences between laparoscopy versus robotics, because I think that's confusing for many patients when they come in. So if we could have Dr. Burke, if you could kind of comment on that, and maybe if we could show image 5.
Sure, I will. I just wanted to add, Todd, one thing about the benefits of laparoscopy from a cancer perspective. So one thing that also is important is that with the minimally invasive laparoscopic or robotic approaches, oftentimes what kept our patients in the hospital 3 to 7 days with recovery, patients are leaving the same day. And as Julie and Sarah pointed out, there's a much quicker recovery. And what that leads to from an oncologic standpoint is patients that require postoperative treatment with radiation or chemo are also starting those treatments sooner and finishing their overall treatment sooner. And it leads to a great sense of satisfaction to the patient. So I just wanted to add that. Now, moving on to the difference between robotics and laparoscopic surgery. So the main thing that I try to tell my patients is that robotics and laparoscopy are the same surgery. They're both minimally invasive approaches to difficult procedures that have traditionally been done open, right? They both use small incisions, they both use cameras, and then they both use very enhanced and precise instrumentation. The difference with robotics is robot really was developed to overcome some of the limitations that we had with minimally invasive surgery. Number one was we operated in 2 dimensions. So we're operating in a 3D cavity in the belly, but we're seeing it in 2 dimensions. And so doing advanced surgical techniques in that standpoint, such as clamping or suturing, was very difficult for surgeons and took a lot of practice. So robotics provides, unlike minimally invasive standard laparoscopy, provides a 3D imaging system, as pointed out. It also provides wristed instruments, and then the surgeon console, which we'll talk about. So maybe we should go to, can we go to image 6? So the wristed instrument, the design as previous was standard laparoscopic instruments move in 4 degrees of freedom. The robotic instruments move like the human hand with 7 degrees of freedom. So often when we're suturing or doing advanced techniques with the robot, we're able to move the instrument like as if we were doing open surgery. So that's very important. So let's go to video 2 and see how that looks actually. So this is just a small, practice. So you have a grasper and a little ring, and what you're able to see here is that the surgeon can move their instruments in a very precise way with small movements that are very controlled. Yeah, we think it's cool too. I mean, the amazing thing about the robotic systems is you can put students on this, and within 5 to 10 minutes, they're able to do surgeries and techniques like that very easily. So let's go to video 3 and look at some of the advanced suturing techniques that we're able to do robotically. So this is representing an open incision or a skin incision or in the body for a myomectomy, where once we've removed the fibroid from the uterus, we have to close the uterus and make it whole again. So we can suture with tremendous precision here. And these videos are kind of all over the internet, but you sometimes will see the robot peeling grapes and closing and doing origami. So these are all really, really amazing things. And what this has led to is laparoscopy was a way to do difficult surgery, but what robotics has done is taken all the benefits of laparoscopy, and now we can apply it to the most difficult scenarios, and patients have derived great benefit from that. And I think last, for the surgeons, let's look at video 4. The last greatest thing is preservation of surgical wellness. So the surgeons are at the console controlling the robotic arms, and that's very important for the overall surgery. But what it's really translated into surgeons is minimally invasive laparoscopic standard surgery, very hard on the surgeon, standing for anywhere between 2 and 8 hours with multiple cases a day. It's very hard on the shoulders, the back, and the legs. And the robotic console is created to be ergonomic to alleviate a lot of the pain and suffering, so to speak, that surgeons have, which in the long run will increase a surgeon's longevity and the ability to them to actively operate on patients for a greater time in their career.
Yeah, and I think the 3D vision cannot be, is really important. It really has allowed us to see much better. And I think that's one of the things that I think as people do more and more minimally invasive surgery as opposed to open surgery, is there is a much better ability for us to see even with 2-dimensional laparoscopy or 3-dimensional laparoscopy. Because when I'm normally operating, if I'm operating, I'm looking at the vision of my hands when I'm doing something open. But when I'm doing something laparoscopic or robotic, I can bring that camera right up to the tissue. So it really allows us to do much safer surgery, allows us to visualize important structures, to minimize, and to improve outcomes, which I think is really important. So I think all those different things are really, helping us to really take, what procedures used to require a big open procedure and make it into a much better outcome for our patients.
Yeah,
so let's talk about.
So I just want to add one thing. The other thing is the camera is magnified, and for learners and patients, robotics, the cameras and the optics through minimally invasive surgery has enabled us to see things in the pelvis that have made us better open surgeons. So I just like to tell my patients that the technology that enables us to do this has made surgeons better all around and seen anatomy and things that we were never able to see early on.
Yeah, and I think for those of us who are sort of on the older end of the spectrum here, we've seen that growth, right, over the last 20 years. And I think, Dr. Burke, we're lucky as he was actually one of the team that originally was part of the approval process for robotics and gynecology. So having someone like himself and someone like me who was at the forefront of robotics and laparoscopy, I think really does, help from a perspective of for women in Suffolk County, for women of Long Island, having access to those type of techniques. And again, I think, when you look at what are the different things that we can do, let's talk through each one of the different specialties and really talk about what conditions that can you treat through a minimally invasive approach. So why don't we start with urogynecology with Dr. Player and let him kind of talk to the audience about what he can do.
Yes, when you include vaginal surgery as a minimally invasive approach, an overwhelming majority of urogynecologic procedures are done minimally invasively. Hysterectomies, urinary incontinence procedures, prolapse procedures, all have a vaginal approach option for their management. However, kind of going in line with the laparoscopic robotic talk that some of my colleagues have been bringing up, those are also options for urogynecology. I would say one of the most common procedures that we do from a laparoscopic robotic approach would be a mesh-based prolapse repair. This is a type of repair that is a great fit for some patients. And with the robots, not only can we do the procedure through the tiny incisions, but to echo what Dr. Griffin and Dr. Burke were saying, the 3D camera with the ability to really zoom into the tissues that you're working with when you're dealing with delicate structures in the pelvis that has such complicated anatomy, it becomes really helpful and helps increase the safety of the procedure.
And then I think, when we look at what we've been able to do from a GYN cancer perspective, Dr. Burke, I'd love for you to expand a little about how really these minimally invasive approaches have changed what we can do from a women's cancer perspective.
Sure. We can basically address most cancers minimally invasively. So what that includes is presumed early ovarian cancers that have responded to chemotherapy that have surgery after receiving chemotherapy, all uterine cancers, and cervix cancers. And last, one of my favorite is that for women with early cervical cancers that have not had children, we do have the capability of maintaining fertility, leaving the ovaries, the uterus inside by removing the cancer very precisely on enabling those women to go on to have babies. In fact, I got an Instagram post on Mother's Day from one of my patients that we did in 2008, and she's had 2 children since that time. So that's amazing. And previous to minimally invasive robotic surgery, all those procedures were done open. And again, the patients were in the hospital for 3 to 7 days with 6-week recoveries, where we often, as I trained and when I was a younger attending, we'd have anywhere between 8 and 15 patients in the hospital recovering for their surgeries. And today at Stony Brook, I'm glad to say that it's rare for us to have more than 1 patient in the hospital, and it usually has nothing to do with recovering from surgery.
And could you talk a little, Dr. Burke, about how Sentinel Node
Sure.
has been important from a uterine cancer perspective and how that's changed the outcomes for patients?
Sure. So Sentinel Nodes, the concept of Sentinel Nodes is to identify the lymph nodes or the lymph glands, which are the glands in the body that drain cancers. So it's a way that cancer can spread in the body. So often for cervix, uterine, and ovary cancers, we identify those lymph nodes that may contain cancer to provide a stage of prognosis and guide treatment for women. Traditionally, we had always removed all the lymph nodes or a majority of the lymph nodes, and that can lead, as a lot of people are familiar, to lymphedema or swelling in the legs or the feet, and that's a big problem for patients. So the technique of Sentinel Nodes is we identified or pinpoint the first nodes in the chain that if there's no cancer there, there's a very low likelihood of having cancer anywhere else. And the minimally invasive techniques have that both for standard laparoscopy and for robotics, where we use an infrared camera to identify the lymph nodes and in very precision surgery just remove them. And that's led to, again, less surgery, more precision in cancer diagnosis, and less side effects with lymphedema, swelling, and postoperative suffering.
Yeah, and again, I would just echo, I think, nowadays, what you guys are able to do from a cancer perspective is really amazing, and it's tremendous for patients, and I think women are really benefiting from that. I'd like to move now more onto like our benign conditions that we can treat. And let's start with Dr. Leanne first. Let her talk a little about maybe how fibroids have been treated differently nowadays. And then maybe we'll have Dr. Kim talk about endometriosis.
So yeah, I would say fibroids are, a big majority of a lot of my practice, as well as Dr. Griffin and Dr. Kim's. Fibroids we can remove surgically, either through a myomectomy, which is removal of the fibroids, or through hysterectomy, depending on what the patient desires. And having in my residency, I do remember doing larger incisions for either myomectomy or hysterectomy, and seeing those incisions and how the patients recover afterwards. It's a longer recovery, as we discussed. And then now in my career, even for larger fibroids and larger uteri from the fibroids, being able to do them through little incisions, either laparoscopically or robotically, and then seeing the patients, in the office a week or two later, and they're feeling great and they're mostly back to normal activities. And that's really amazing. And it's great for us to be able to offer that for women. And then when you see them and look at their incisions, most of the time when they're healed, you can barely see the incisions. And so I think most of the surgeries that we are doing, we can do open, we can also do laparoscopic or robotic, especially fibroids.
And I think maybe you could touch a little about on how we actually get out these big fibroids. So maybe talk about how, like, some of these fibroids could be the size of a basketball. They can be signs of melons. There can be multiple.
Yes.
So talk about a little about how, you take these large fibroids out.
It's a magic trick. Never mind. It is
truly.
Yeah. I mean, sometimes patients come back and they're amazed how we were able to remove, large fibroids through little incisions. So typically, if we're doing a myomectomy, we are after we've finished removing the fibroids and we repair the uterus, we enlarge typically the belly button incision to about 2.5 centimeters, and we pass in a very small bag, and we put all the fibroids in the bag, and then we basically use scalpels to remove the fibroids out from the little incision in their belly button. And so that way everything is contained within the bag. Nothing is left. No fibroids are left in the abdomen or pelvis, and then once the patients heal from the belly button, you can barely see the incision most of the time.
Yeah, I think that's a really important point to make, because I think sometimes patients wonder, how do you get this large, because they can see it sometimes on their belly. They'll feel like they're pregnant, they'll look like they're pregnant, and the fact that we've been able to develop these techniques is really important. I think, I'd like to hear Dr. Kim talk about endometriosis, another very common condition that we're treating minimally invasive.
Yeah, so endometriosis, for some patients who may not know, so it's usually associated with cyclical pelvic pain, where patients have severe pain during the time of menses, and there are a lot of good medical management options out there. But endometriosis could also be associated with endometriomas, which are ovarian cysts that are formed that do usually require surgical management. And what laparoscopy and robotic surgery and basically minimally invasive surgery have done for endometriosis is that I think the best tool for the surgeon for these cases is that you have really great visualization. And I think you could do these surgeries open, but being able to see with these like 3D vision for if you're doing it robotically, or be able to see up close, seeing where the ureters are, they're making sure all able to identify these very important anatomic landmarks. You're able to do these endometriosis surgery a little bit more precisely, and I think what the key is that it just had made the surgeries easier for the surgeons. And then if it's easier for the surgeons to do, laparoscopically and minimally invasive, then it's better outcome for the patients, because then we're able to complete the surgeries a little bit quicker and more effectively, and be able to resect all the endometriosis that we may see. And I think robotics and laparoscopic approach has kind of enabled us to do that a little bit precisely in terms of endometriosis.
And I think, one of the things that Dr. Player touched on, Dr. Burke touched on, and we've been touching on, is this idea that we can do what we call uterine preservation. So Dr. Player talked about that from a prolapse perspective, when people have prolapse. Dr. Burke talked about that from a cervical cancer perspective. And I think on the benign side, this is one of the things that we've seen as well, is that, many times patients came to us and, they thought they had to have a complete hysterectomy, or they had to have their ovaries out, et cetera. And, we're able to now do surgeries, very complex surgeries, where hopefully we can either improve the patient's fertility or maintain their fertility, which is, I think, really important. And I think many women need to understand that when they're talking to their OBGYN or to their surgeon, is that, are they making sure they're getting the right procedure? We'll talk a little bit about that after. And we do have a question from the audience, so I'll put this back to Dr. Kim and Dr. Leanne. So when does endometriosis most commonly present itself in women? Is it a specific age, or is it any age?
Dr. Kim, you want to take that?
Yeah, sure. So endometriosis could usually, generally speaking, it could present at any age, but I would say most of the time it presents, in probably the early 30s or 40s. A lot of times there might be a little bit of a delay in diagnosis because oftentimes patients may say this is just part of me having painful periods, so this is probably just not endometriosis. So there is definitely a little bit of a delay in diagnosis of endometriosis, but I would say most common age of presentation, if you're doing the full workup and you meet a surgeon or a gynecologist who treat endometriosis often, I would say the age that presents is usually in like the 30s to 40s. A little rare for endometriosis just kind of pop up in the 50s, or even obviously for menopause, you're not really going to have those symptoms. So I would say my most common is probably early 30s is when I'm seeing these patients. But it doesn't necessarily mean that people in their 20s don't have it. Sometimes there just could be a little bit of delay in diagnosis.
Yeah, I would agree. I think most of the time we're going to see patients presenting because mostly around infertility, sometimes as you said around pain. So usually the infertility patients are going to present a little later. The pain patients will often see earlier, especially if they've had endometriosis since they were an adolescent. So those patients we'll see in adolescence and in their 20s. But I would agree. Dr. Leanne, do you have any other comments about when it most likely presents?
I agree with Dr. Kim. Typically, we see them, or I see them in their early 30s, and a lot of them are referred by their fertility specialists. But a lot of times I do also see patients, who are in their 20s, and Dr. Kim mentioned a lot of times they've gone to multiple doctors and had gone to multiple even ERs because they're in pain, and sometimes they're told that the pain is normal, and when in fact it's not. So I think for patients who have pelvic pain, especially pain with periods, don't let the physician or whomever you're seeing say that it can be normal. A lot of times you shouldn't have that severe pain.
And just to touch a little more on endometriosis. So, one of the things that you guys will see is that these patients, endometriosis can often be involving other organs besides the gynecologic organs. So how have you guys dealt with that when you have patients who potentially have bladder, colon, other issues? And why is it important to be at a place like a Stony Brook?
So I think it's important to be, when someone has pain or endometriosis affecting other areas, like as you mentioned, bladder or bowel, it's important to go to a place like Stony Brook because we have, other specialties that we work very closely with. So urologists, gastroenterologists, colorectal surgeons. And so, and even, pain psychiatry. And so it's very important to have a multidisciplinary team to help take care of patients who have a complex condition, just like endometriosis. And at Stony Brook, we have that. We have a chronic pelvic pain clinic, and we have established these relationships with the other disciplines.
Great. So let's talk about, why is there still a need for open surgery? Why can't all surgery be done through a minimally invasive means? And maybe we'll just go through each one of the different specialties. So why don't we start with GYN cancer, Dr. Burke?
Sure. So I think there's always a role for traditional surgery and open incisions. Where we see that the most is with advanced cancers, such as ovarian cancer, where the tumor may be spread throughout the belly, which is just not feasible to remove a tumor through small incisions, or large ovarian masses or cysts that are presumed potential cancers that we cannot put in a bag to contain the spread of cancer. And finally, sometimes when there's large fibroids in older women, typically over 50, that are suspicious for possible sarcomas, those also are difficult to place in bags. So there's always a time and place for open surgery. And last, and I know that we all, we've all preached the benefits of minimally invasive and robotic surgery, and that is absolute fact. There are some times with younger patients that have had a previous cesarean section that they don't want even small scars on their belly, and sometimes they will opt to reuse their scars. So sometimes it's a patient's choice as well.
Great. Dr. Player, let's talk a little about for urogynecology.
Yes, so for urogynecology, the short answer is that there are certain times that a patient's anatomy does not allow you to do a minimally invasive approach. As Dr. Burke had said, sometimes it can be pathology that's large, and particularly for us, that could be someone could have a form of prolapse surgery, but have a larger uterus that can make it difficult to do through a minimally invasive approach. I'd say more commonly in the Urogyne world is if someone either has scar tissue or has abnormal or particularly large vessels present in an area that is important for the dissection for urogynecologic procedures. In particular, the sacrocolpopexy procedure has certain portions of the pelvis that we do need to get to, but if someone's anatomy does not allow us to get there safely, then it's not appropriate to proceed, and you may need to do an open procedure in those cases. One of the other things to consider is there are certain patients who are not able to tolerate the positioning that's needed for gynecologic, laparoscopic, and robotic procedures. Specifically, the table needs to be tilted so that the patient's feet are above the level of the head. And for certain patients who have certain respiratory conditions or a large body habitus that can make it difficult sometimes for anesthesia to ventilate those patients appropriately. So those would be some of the scenarios that may necessitate an open procedure still.
Great, and we'll throw that question on the benign side to Dr. Kim.
Yeah, I would kind of, basically go off of exactly what Dr. Burke and also Dr. Player mentioned. For us, I would say the size of the pathology is a big factor. So if we're doing a fibroid surgery and we're trying to do a myomectomy, if it's too large that it's really difficult for us to even put any instruments in laparoscopically, we would make a big open incision. Some of it is patient preference. They like to use prior C-section scars if they had a prior C-section. And sometimes it's also if we're doing, let's say someone has like a big ventral hernia and they're going to be, entering and doing a hernia repair anyway, sometimes we are going to be using that same incision if they're having concomitant surgery, so that we're not necessarily making additional incisions. So I would say pathology is probably the biggest factor, or even some prior abdominal surgery, although that's kind of depending on, if you're concerned that there might be big meshes involved, you want to avoid that. There might be adhesions that you might want to avoid in the sites that we would routinely put laparoscopic trocars. Sometimes we might opt to do open incisions for that.
And so one of the things I think is probably important for the audience to hear is, how often would you potentially be starting with a laparoscopic case or a robotic case and have to convert that to an open case? And I think, I would like to just hear kind of from the panel what their thoughts on that.
I would, Todd, I can begin. I think that it's a learning experience, but I think that surgeons that are comfortable with offering all the approaches that can look at the patient individually, I think what that means, what you're talking about is a conversion rate where you're going to convert to, open surgery. That should really be almost never. So I would think that's somewhere between 0 and 2% of the patients, from barring complications. So I think it's all about good patient selection and communicating to your patient, what the options are.
Yeah, and I would just echo that. I think it's very important for the audience to realize that patient selection is really key, and deciding, do we need a vaginal approach? Do we need a laparoscopic approach? Do we need a robotic approach? Is really important, because I often like to think of the minimally invasive surgeon who has a tool belt with multiple different tools, and you need to use the right tool for the patient. Don't fit the patient to the tool, use the right tool for the patient. So there'll be times where I may see a patient and say, this would be a much better vaginal hysterectomy, and I'm going to send that patient to Dr. Player because he's an expert in vaginal surgery. And so I'm going to make sure the patient's getting to the right place. Or I may say, I'm a little concerned about this patient. Maybe this is a precancer or cancer, and I'm going to make sure that patient goes to Dr. Burke or one of his colleagues to make sure they're being seen appropriately. So I think that's one of the also important things is that, we work as a team, and that team really looks to say, okay, what's the right thing for this patient, as opposed to, okay, how am I going to do this procedure? Yeah. And I think that kind of leads us to the next discussion, is about how do you make sure you have the right surgeon? And I'll just throw that up to the group. Maybe, we could start with Dr. Leanne.
So I think first and foremost, for the patient, you should always feel comfortable with the surgeon or the doctor that you're seeing or you're considering to have surgery with. Don't be afraid to ask as many questions as you want. You're not, burdening the doctor. They're there to take care of you and to answer all your questions. As hopefully we've shown, laparoscopic, robotics, and even, of course, vaginal surgery is great and minimally invasive, but it can be also complex, depending on, the pathology that someone has, their surgical history. And so, medicine and surgery is getting more specialized. And so something else to keep in mind when you're looking at considering surgeons is to ask the surgeon how many of these surgeries, what their experience is and how many of these surgeries they've done. So with, of course, surgery, you want to definitely go see a doctor who is a high volume surgeon. The doctor may not necessarily need to have done a fellowship per se, but again, that doctor should definitely, I would recommend, be a high volume surgeon. And don't be afraid to consider getting a second opinion or a third opinion. At the end of the day, the patient should feel comfortable and have trust in their surgeon.
And maybe Dr. Player, when you talk about Urogyne, maybe just talk a little about what actually is a fellowship, because I think most of the audience probably does not understand what a fellowship is. So it might be good to just talk about that and then talk a little about, how do you make sure you have the right urogynecologist?
Sure. So fellowship is an organized training that someone does after they've completed residency. So in terms of medical education, you have medical school, you have training in residency, which for all of us here was in OBGYN. And then you have fellowship training, which is training in a more special, with a more special focus. So for me, urogynecology, for Dr. Burke, GYN oncology, for Drs. Leanne and Dr. Kim, it was in minimally invasive gynecologic surgery. So that's what a fellowship is a organized, structured training program after you've completed residency. Now, to talk about the counseling of patients, I love this topic because there's can be a lot of misconceptions and confusion about procedures and about conditions within gynecology, but especially within urogynecology. I think that it is important to feel like you have been counseled on the options, risks, and benefits for treatments for your condition. There is no surgery that does not have risks. And I think it's important to try to feel like there is honesty and sincerity from the conversations that you have with your surgeon. A lot of the urogynecologic conditions that get treated, those are quality of life issues. And so unlike something such as gynecologic oncology, there may not be you have to do this to really have the best care option. There can be different options. And I think that it is really important for patients to have a discussion with their doctor, rather their doctor to have the discussion with their patients about what are your goals of treatment and what are your concerns about your condition or treatment. Everyone likes to think that that we're all similar and everyone has the same set of goals and concerns, and that's not true. We are all people. People are different. People have different goals and concerns, and so addressing those in your counseling is important.
And then finally, let's talk to Dr. Burke about how do you make sure you have the right GYN cancer surgeon.
Yeah, I would just like to echo what Andre and Julie said. I mean, I think all those things are apply to GYN oncology. I think when it comes to cancer surgery, I think we're all very well trained, and I think most surgeons in the United States offer similar things. But I think above and beyond the counseling and the experiences, you have to connect and trust the GYN oncologist. So I always tell my patients, because we often, say get a second or third opinion, you have to go where your heart and your gut says. So you really have to connect with the surgeon.
Yeah, and I think that's really important. I think especially for us as consultants, because many times we are, patients are coming to us as a second opinion or potentially even a third opinion. And it really is important that we as the surgeons really explain to the patients thoroughly what we're doing, what their different options are, making sure that they're getting to the right provider. And that may not be me all the time, and that may be somebody else. And as well as, like you said, building that trust, because, when you look, I think when you look at experience, as Dr. Leanne was saying, it really is important to look at, what is the amount of surgery that this provider is doing. If you look in New York State, the average OB/GYN does 4 to 5 hysterectomies a year, where people on this panel are doing 100 to 200 hysterectomies a year. So, that's a big difference in what the providers in a team like this are able to do versus the routine OB/GYN out in the community. I think that's, from a patient perspective, patients need to understand that, and need to understand that it's okay to look elsewhere to find care. And whether that's with us here or whether that's at another potential academic medical center, that's the benefits of having a Stony Brook in their neighborhood, is that we have all this advanced training here, especially for women, which I think is really important. I think the next thing I'd like to kind of just say is, and maybe we could show slide 4, is where is minimally invasive surgery robotics going? Where do we see things happening? So, I think we talked a little about this, but maybe you guys could talk a little about where you see the future of minimally invasive surgery robotics.
Yeah, so I have one that is exciting to me from a cancer perspective. One of our big jobs as cancer surgeons is to make sure that cancer hasn't spread beyond the organ, outside the uterus, beyond the ovary, or beyond the cervix. And that's traditionally been through random biopsies based on anatomy. And some of the technology that's coming, and I've actually saw it, it's not quite ready for prime time, but we have the ability to use antibodies or tags to tag cancers and light them up under sophisticated optics. And so we looked at a technology that may be available soon, and where you can inject the patient with a tag about an hour before the surgery, and then during the surgery use the camera to light up the cancer that's in the belly and make sure you remove it all. So there's a lot to come from an oncologic standpoint. That's really exciting.
And similarly, they are looking at things for endometriosis similar to that, because sometimes, again, it can be very difficult for us to visualize the endometriosis. Endometriosis can look very different in different patients. And so, having that ability, and again, having an experienced surgeon to know what endometriosis can present and look like, is very important. Does anybody else have any other thoughts about where robotics or MIS is heading in the future? Great. Well, I want to again offer any questions. Please put them into the comments section. In the meantime, again, thank you everybody for tuning in. We hope you found that this discussion was informative. Again, if you'd like to follow up with any of the providers above, we have put up the phone number for appointments at 631-444-4686. You can also visit our website at womenshealth.stonybrookmedicine.edu. There's a lot of great information there. You can learn, and then also we do have a Facebook page, so you can follow us on University Associates in Obstetrics and Gynecology. And I'll give it a minute to see if we have any other last questions. But thank you, everybody.
Thank you.
Yeah, thank you.
Thank you.
Thank you.